everybody, and welcome. Thank you so much for being here with us tonight. I know we're still have some folks that are joining us, and they will continue, to float in. But I wanted to be mindful of your time and kick us off. So just thank you so much for being here. This is the second panel as part of our Kick It Cancer initiative, and we are just floored by the feedback that we've gotten from you all. I was really impressed by all of the questions that came in. The goal of this evening is to really promote prevention, awareness, and screening for prostate cancer. And you all have shown that you have a deep interest and are vested in this topic, in reducing the disparities that we see in our surrounding communities. And we're just so grateful that you're here with us tonight and to hear our amazing speakers and get some of those questions answered by our panel. So I'm going to introduce some of our staff that's here with us tonight. We have Cynthia Turnquest. She's our Director of Outreach and Strategic Partners. And then we also have Jason Kiefer here with us tonight. He is in charge of our men's programming. And we're just going to have him say a few words just about what we have going on, what we have to offer, and if anybody does need support, to reach out for sure.
Yeah, thanks, Kathleen. And thanks again to all the gentlemen who are here today. So yeah, I've been running our men's programming for several years now. And I'm just so glad that this is happening. I was just sharing with everyone before that we used to have robust prostate cancer programming, and just over the years that has just dwindled. And we can't quite understand why. I mean, honestly, we're not even getting the referrals or anything. And we really, would be glad to keep offering that. We do offer men's programming, a weekly networking group for men with any type of cancer. So, anyone interested, please reach out to us regarding that. We can get you into that group if you would like. But hopefully this panel kicks us off to some more prostate programming. I know there's some great speakers here. Dr. Desai has presented for us in the past. We always get such great feedback from him. So I'm just really excited. I think it's time that, people realize this is something that there is a lot of resources and support for. And, we just want to be helpful. So just thanks again to everybody. This is really great. I was going to be a bigger part of it, just COVID stuff. I got stuck with dad duty tonight. So I'm probably going to turn my camera off and unmute myself because we're very close to dinner, bath, and bedtime. But I just wanted to be a part in some capacity because I'm just so glad it's happening. So thanks again.
Thanks, Jason. All right. Well, our first presenter that we have for you tonight is Vikas Desai, MD. He is a urologist who treats all urological conditions in both men and women, including male and female urinary incontinence and urological cancers. Dr. Desai is especially skilled at performing minimally invasive laparoscopic techniques, including the Da Vinci robotic surgery techniques. And he also specializes in treating erectile dysfunction, I'm going to say this wrong, Peyronie's disease, and low testosterone and urethral strictures. So I'm going to share his PowerPoint in just a moment here.
Actually, I could probably just share my screen. That might be easier.
Oh, okay, sure.
Yeah, let's do that. Maybe easier to flip through. So
take it away.
Awesome. All right. Well, thanks for the Cancer Support Center for organizing this great event. I think it's quite important at this time of the pandemic to talk about a lot of this prevention, especially prostate cancer, as some of this care is being delayed. And so I want to try to target on kind of the most important points of when we should look into prostate cancer and what we should do about it. And obviously Kathleen gave me a great introduction. From the Chicago area, born and raised, huge Chicago sports fan, kind of difficult these days, especially if you're a Bears fan, but for the essence of time, I'm going to move on from that. And so what we want to talk about today, or what I want to kind of focus on, is kind of the incidence and prevalence of prostate cancer, some of the screening, detection, and prevention. Prostate cancer is pretty important. It actually kills about 35 men every hour. Most commonly diagnosed cancer in men. Now, there are about 240,000 cases that are diagnosed annually, and a vast majority of them are localized disease, but there are people who do actually die from this disease, up to 3%. It is a disease of older gentlemen, so then it comes down to the question, when do we start screening and when do we look into it? And I'm going to unpack this pathway here. This is, I think, a great resource. Even they have a great patient arm as well from the National Comprehensive Cancer Network. But the main points I want to talk about in terms of screening is getting a baseline PSA. I think, we have a survivor who's part of our panel tonight. And I think I can't stress enough getting a baseline PSA sometime after the age of 40, especially if you're African American. There's multiple studies, and I'm sure one of our panelists will talk a little bit about this in greater detail, but about a 63% higher chance of prostate cancer, 2 times higher increased mortality. Some of the things that they've looked into this is, access to healthcare maybe might play a role into this. There are some genetic things, biomarkers and stuff are kind of playing into this. And I know one of our panelists will kind of hit on that. But bottom line, baseline PSA, I think is very important. There's linkages with breast cancer, one of the mutation genes, the BRCA gene, especially the BRCA2 mutation has a 2 to 6-fold increase. So obviously, if you have a family history of breast cancer or even ovarian cancer, I definitely recommend maybe an earlier screening start point. Otherwise, a baseline after the age of 45 is fairly reasonable for everyone else. And I think one thing that I'll run into many of my patients, they don't want to get that rectal exam. And I will say this much, the rectal exam might not have as much importance as it used to maybe 15, 20 years ago, but I think it still has a significant deal of relevance because it can pick up to 15% of these prostate cancers. So with that, I think one thing, obviously we've decided when to start, but I think getting a PSA every year is not necessarily something that we need to do for everyone, right? If your PSA is very low, less than 1, maybe every 2, even up to every 4 years. And what this does is actually create some of the anxiety that men may have coming into the physician's office being like, oh, I have to get that rectal exam again, or I have to get that again. And so this way we can still screen appropriately so that we don't miss cancers, but at the same point, not subjecting patients or to some of the harms of screening. Obviously, we don't have to go on forever. After a certain age, I would recommend stopping, or if you're unhealthy. I think one of the things that I do a lot with my patients, and I'm sure many physicians do this day at this point, but making sure you're involved in the decision making, right? I want to make sure you all are involved in the process. And so if you just say to me that, hey, I want to stop checking my PSA, or I want to check a little further, I want you to be aware of what we're getting into in either approach. And I think that's very much paramount in any decision we make in healthcare. The next focus I want to have today is on something known as detection, right? So we've done all this stuff with screening. We've come back with some values of a PSA, maybe with a rectal exam. When do we actually biopsy, and what are we going to do before we biopsy? Are there any other tests before we jump to that next thing known as a biopsy? So basically, PSA is a big cutoff. So I think there's a differentiation if you're older or younger than 75. And this is straight from the National Comprehensive Cancer Network. But basically, if you're above 75, I think there's a little bit of a threshold where we might have a higher PSA. Obviously, most men above this age are not getting PSAs done. But if you are, for some reason, a little bit of a higher cutoff, I think an abnormal prostate exam is going to probably lead you down the road of a biopsy. But a prostate MRI, and I'll talk about that on the next slide here, but I think if you have an abnormal prostate MRI in either scenario, a lot of times I would recommend a biopsy. And some of these adjuncts that are out there, like prostate biomarkers, I've listed some there, or prostate MRI, the idea of why we want to do these things first before we jump straight to the biopsy is we want to pick up the most clinically significant and high-grade cancers, right? The low-risk cancers, as we know, are more likely than not going to cause you any harm. And so we don't want to necessarily put you through a biopsy, which can cause, temporary harm, but blood in the urine, blood in the stool, blood in the semen, small chance of a hospitalization or an infection. And we want to minimize those risks. Another thing that a lot of times I'll do for men is just simply repeating the blood test. We can't fully explain it. I mean, there are definitely some reasons why PSA can be artificially elevated. But 25% of the time when I repeat the blood test, if the number is between 4 and 10, it's just going to come back normal. And we'll just chalk it up to inflammation. Doesn't mean we'll forget about it, but it's something that we would recommend before we jump to that biopsy piece. Another thing I think is very important is the free to total PSA ratio. It basically, the PSA is a protein made by the prostate, and it's bound to another protein. And so if there's more of it floating around and not bound, it's less likely to be cancerous. And so if that percentage is above 25%, we can avoid up to 20% of all prostate biopsies. You know, if you had a normal MRI of the prostate, you know, studies have shown you can avoid up to 30% of unnecessary prostate biopsies. So that's why these adjuvant tests are quite important. I think, you know, as I said, an abnormal prostate MRI, we can increase our yield up to 25% of the time. You know, if the percent free PSA is less than 25, then that's a good way to pick up almost 95% of cancers if you end up doing a biopsy. Now, that being said, there's one other thing that I'm not going to talk about too much right now, are biomarkers. And this is more institution dependent. I think with my organization, we have a system where patients are able to get these prostate MRIs in an outpatient setting where the cost is less than $1,000, right? That doesn't necessarily apply to every institution. And so for us, we're not using biomarkers that often because we do have the increased utility of an MRI. We have only a select few radiologists looking at it. And so that increases the overall interpretation and the quality of the imaging. But the bottom line, what I want to point out is there's additional tests many urologists these days do before they jump to a biopsy, whether it's an MRI, whether it's repeating the PSA, getting a ratio of the free to total, or even doing a biomarker in some institutions. The whole idea is, can we get a better yield from the biopsy and minimize the harms? Now, that being said, I want to point out this last thing here. They're not perfect measures, right? So if you have a family history, your PSA keeps going up, everything else checks out, right? Your MRI is normal. Let's say your percent free PSA is above 25%, but if your PSA keeps going up, I would still potentially consider a biopsy on you, and it would involve you in the decision-making process. And the reason is that there are cases that don't meet all the rules. And that's where that shared decision-making and individualized medicine is very important. And so what I want to end with is this. In terms of prevention, right? I think that's the big thing, right? We've talked about screening, we talked about detection. How do we actually prevent prostate cancer? Really, the only thing that's been proven is early screening, right? There's a lot of different things that have been talked about, right? What if I change my diet, right? I think dietary changes for, you know, if you have high cholesterol or if you have diabetes or high blood pressure, I think healthy eating for those facets are quite important, but there's not really anything specific in terms of prostate cancer. I mean, they've looked at vitamin E, they've looked at selenium. I'm sure one of our panelists here might mention some other stuff, and there might be some newer research in that, but so far, everything they've looked at hasn't really been able to be applied to a widespread population. They've talked about different medications for diabetes, like metformin, or something for high cholesterol, like, you know, like your statin drugs. And they really haven't, they've shown certain benefits, but overall, I can't generalize them. And so I always tell people, I think the biggest thing for prevention is early screening. And so with that, I'll turn it over to Kathleen to turn it over to our other panelists and leave some time at the end for some questions. So thank you, guys.
Great. Thank you so much, Dr. Desai. That was wonderful. So we're going to introduce our next speaker, Dr. Dickey. And Dr. Rasul Dickey was born and raised in the Chicagoland area and attended Rich East High School in Park Forest. He continued his education at Xavier University of Louisiana, where he earned a Bachelor of Science in Biology and Doctor of Pharmacy in 2006. Dr. Dickey is currently a specialty pharmacist for Caremark, working with patients diagnosed with disease states such as cancer, multiple sclerosis, pulmonary arterial hypertension, and HIV, amongst others. He was previously a community pharmacist in Houston, Texas, and while there led various outreach programs such as AIDS outreach, flu and pneumonia vaccine drives, diabetic screening, as well as food and clothing drives for the homeless. Dr. Rasul Dickey is currently active in various programs and organizations such as the Prince Hall Masons, Kappa Psi Pharmacy Fraternity, an Omega Psi Phi fraternity incorporated, and continues to strive to educate and impact the community. I'm going to go ahead and find him in our screen here. There you are. And then I will spotlight you and take it away.
Okay, thank you, Kathleen. Go ahead and bring up my presentation really fast. Okay, all right, we're just gonna do this the old school way. I'll just read off of my screen and present. Okay, so we'll stop sharing. Okay, so for those who know, my name is Rasul Dickey, Dr. Rasul Dickey. Thank you to the Cancer Support Center. Thank you to Mr. Hubert Stalling and the Chi Lambda Lambda chapter of Omega Psi Phi. I appreciate it. So let's see here. All right. So I want to start off with speaking about what are the major causes of death amongst men, especially African American men in particular. So I pulled up a chart, and this chart was taken about 2 years ago. The number one cause for death amongst men, particularly African Americans, is heart disease. The second is cancer. The third is accidents, which can be intentional or unintentional, such as car accidents, things of that nature. And one of the last ones is diabetes. So I want to keep this all in perspective. I want everybody just to keep this in the back of their minds when we go further into this presentation. So prostate cancer is actually the number one cancer that is diagnosed amongst African American men. The second is lung and bronchus cancer. Third is colon and rectum. So our top three cancers that we see amongst African American men are prostate, lung and bronchus, and colon and rectum. Now, deaths from cancer that we see amongst African American men, number one is lung and bronchus, number two is prostate, and number three is colon. So my job when it comes to prostate cancer is I do a lot of speaking with patients on top of checking their medications to make sure that there's no interactions and stuff, but I make sure that they have a good quality of life. Because once you get into taking a lot of different medications for different conditions, it can wreak havoc. And we want to make sure that we're getting the right medications and making sure that they're getting a good quality of life and still getting the adequate treatment that they need. So what I do at my job is we do androgen suppression. We do it through injections and sometimes through oral. Some of the side effects or some of the effects of androgen suppression are sexual dysfunction. So sexual dysfunction, as you know, can wreak havoc on someone's life. It can wreak havoc on their marriage, and also it can cause depression. There's no real reason for me to have to explain why this can cause depression, but that's one thing that I talk to a lot of patients about. Another is fatigue. Why is fatigue important? Because fatigue can actually keep you from being able to do your job at certain points. Some people have to get on disability. As far as the quality of life, some fathers are unable to attend their kids' functions. Some grandparents aren't allowed to or don't have the energy to interact with their grandchildren. And some people are unable to do hobbies such as bike riding, sports, whatever it may be. Another symptom is, or another side effect is hot flashes or gynecomastia. Hot flashes, as you know, a lot of women get during menopause. Gynecomastia is pretty much when a male has feminization of the breast. And a lot of men, even though it seems like that may not be a big deal, it really is. A lot of men actually opt for surgery to get rid of this condition if they do get it. Also, muscle weakness or muscle loss. This is accelerated when you're getting androgen suppression therapy. As the gentleman, as the doctor spoke before, a lot of older people get prostate cancer. And as you age, you already are going to lose muscle mass. And when you drop testosterone, it's going to accelerate that. So just imagine just being an older gentleman and everything's going great, and all of a sudden you have no energy and you're getting your muscle just wiped out. Also depression, just inherently lowering testosterone can cause depression and can cause irritability. And the last thing that a lot of people don't understand that this can cause is increased cholesterol. Now, we know that amongst a lot of our population, a lot of people have diabetes, high blood pressure, and increased cholesterol. So that's a risk within itself as well. So one of the medications that we give out, just as an example, is Leuprolide. This is a medication that can be injected either sub-Q or IM, which means under the skin or into the muscle. The good thing about this medication is that when you give it to a patient, they don't have to worry about it because these injections last anywhere from 1 month to 1 year. So you don't have to worry about compliance with these medications. This same medication actually treats other conditions such as precocious puberty, which is when young children are growing sexually too fast, meaning that young children are developing breasts and things of that nature. So this can also treat that. This treats endometriosis and also fibroids amongst women. What this medication does is it triggers the pituitary gland to stop making luteinizing hormone, which is vital in producing testosterone. The reason why we want to lower testosterone is because prostate cancer feeds off of testosterone. It grows bigger and spreads due to testosterone. Now, this medication, even though it's great and it works well for patients because they don't have to worry about it, is commonly referred to as chemical or medical castration because essentially it lowers your testosterone to nothing. Now with this medication, some of the common side effects can be flushing of the skin, which is hotness or redness. Peripheral edema, headache is a major one. Migraines is a major one. Depression is a major one. Insomnia, dizziness, hot flashes, increased serum cholesterol, increased triglycerides. Now, this is a treatment for prostate cancer, and this is the side effect of it. So you can see where this can be a major problem amongst men who are already dealing with these issues. So as a pharmacist, I have to go back and look at their medications that are no longer working correctly because they're now being treated for prostate cancer, and it's throwing everything all out of whack. So some of the warnings to use in a medication like this. Androgen deprivation therapy can actually cause QT prolongation, which is an irregular heartbeat that can cause sudden cardiac death. We spoke hyperglycemia or disruption of glycemic control. Diabetic patients, the same insulin that they've been using for years no longer is working correctly. A doctor has to go back and tweak their doses, so that can cause all sorts of issues. Depression, irritability, tumor flare. One thing about these medications, even though it lowers testosterone, it can briefly raise it for about 5 to 12 days. And the tumor flare actually can cause difficulty with urination, also can cause bone pain if the tumor is big enough. So that's one thing that one of the drawbacks to this medication. And also decreased bone density. When you're dealing with older patients who are males still can get osteoporosis. When you're on a medication like this, you can become extremely fragile. I speak to a lot of patients who do a simple fall, and for regular people like myself and you, we just bounce right back up. But for someone who's on these type of medications and is elderly, they can break a bone like that. I'm going to speak about another medication briefly, Zytiga. This one's different because it's a pill that you can take by mouth. A lot of people like this one because I've heard that it causes less sexual dysfunction, and also depression and agitation is less with this medication. Unfortunately, with this medication, again, it can cause hypertension, hyperglycemia, hypernatremia, which is too much sodium in the blood or the body, hypertriglyceridemia, which is increased cholesterol. So as you can see, it's not just the therapy or being diagnosed with prostate cancer that is an issue. This affects your whole life. This affects a lot of people who are dealing with minute issues and now makes some major issues. Now, going back to the chart that I was speaking about with African-American men. As I stated before, new cases, prostate is number 1, lung and bronchus, colon and rectum is number 3. Unfortunately, death amongst African-American men and minorities is mostly due to lung and bronchus. With me saying that, I want people to realize that I deal with a lot of patients who not only are dealing with prostate cancer, But because lung and bronchus is the #1 amongst African-American men, I'm dealing with some people who are dealing with 2 cancers, lung cancer and prostate cancer, as well as diabetes, hypertension, and high cholesterol. So in conclusion, you can see that this condition, even though it's highly treatable and the death rate for it is low, it affects your family, it affects your personal life. It can make it harder to treat your regular conditions that are normal with age. And pretty much the take back is the earlier that you can get this detected and the healthier you are, the better the outcome will be. All right, thank you.
Thank you, Dr. Dickey. I'm sorry, I just realized I was muted. I think there's going to be a multitude of questions that arise based on really the sobering and truthful information that you just shared with us.
Right.
And so I am going to turn it over to Dr. Murphy in just a moment here. Dr. Adam Murphy is an assistant professor of urology and preventative medicine at Northwestern University. He is a general urologist who studies health disparities faced by minorities in prostate cancer, including HIV-infected men and African Americans. His team has been looking at the role of vitamin D deficiency, genetics, and biomarkers in men diagnosed with prostate cancer. His clinical interests include general urology and men's health. Welcome, Dr. Murphy.
Thank you. I really appreciate the opportunity to be here. And I really recognize that the people who preceded me are going to do such a good job that I would have to change my presentation as it happened. They stole my thunder, but I'm going to go ahead and adjust to it. So it's actually a little bit altered.
It all bears repeating, so by all means.
Well, let's see how it goes. I just actually did it as a Word document to try and make myself be limited to just the 10 minutes. So let me work on this real quick and tell me if you can see what I'm showing. Can you see my
Looks
screen?
great.
Okay. So my angle on prostate cancer research has been because I am a urologist and, like Dr. Desai, treat prostate cancer patients, but then I felt like oftentimes the statistics that I were quoting to my minority patients were not accurate. That the outcomes that I talked about, that the safety of treatments, the accuracy of different tests were actually not the same, but I didn't have any proof of it. So I kind of started off my career kind of wanting to see if the increased risk of prostate cancer that Black men face, or the different treatment patterns that HIV infected men kind of receive when they have prostate cancer could be uncovered. If I could do a better job of digging into that through the research, I could probably counsel patients better to make better decisions. So some of what I'm going to talk about is, it's almost as if I'm doing a remix of Dr. Desai's talk, because there are just some nuances that affect men of African ancestry maybe a little bit differently. And so the reason why that is because if you have a difference in the prevalence of prostate cancer, how common the disease is, when you use a screening test or a test to help you detect prostate cancer or measure its aggressiveness, we usually use a threshold like, PSA greater than 4 warrants a biopsy, for example. When you have a population which has higher risk of that disease, to make it as accurate in detecting prostate cancer, you may have to shift that threshold down so that you go with a lower threshold. And there's enough genetic differences between Hispanic, African American, and white prostate cancers that you may actually need to figure out whether or not the actual biomarkers that we commonly use as urologists work the same. Because sometimes you have to adjust the values, the predictions from those tests so that it fits your population better. So as Dr. Desai and Dr. Dickey said, prostate cancer screening saves lives. It's reduced the mortality rate by 50%. And if you actually catch prostate cancer early, it has like a 98% 10-year survival rate, which is better than most cancers. And it's true that all the big studies show that PSA is where most of the magic is, and that digital rectal exam detects about 15% of the prostate cancers that the PSA would miss. It turns out that we did a study about 3 years ago, and we showed that the importance of the rectal exam is more in African-American men or men of African ancestry. So you can see here in this graph that I took from my own paper, so I'm not stealing. I cited myself though. If you have an abnormal rectal exam, which is suspicious digital rectal examination, it does increase the risk of a tumor you'd want to treat a little bit, from about 15 to 18% if you had a biopsy for an elevated PSA, and you had an abnormal rectal exam, it would increase your risk of an aggressive tumor by about 3% on average. But for an African American, it more than doubles the risk of an aggressive tumor, one that you want to treat versus just being able to watch it. So the rectal exam is actually much more important in African American men than it is in non-African American men. So I wanted to make sure that people actually consider putting that in their regimen and try not to refuse those when their doctor offers it. It's not fun, but it's an important test. You know, people ask me oftentimes why there's this, the most recent estimate is about 70% higher risk of prostate cancer and about more than double the mortality rate. And the question is why that happens. And there's a really prominent urologist that I'm sure Dr. Desai also knows, and several of you may have even heard of him. His name is Otis Brawley, and there's another guy from Vanderbilt that is really well known for kind of being a dissenter in the normal way we do things. But it looks like genetics is an important part of it, environment is an important part of it, and how and when you receive care is a major part of it. So if you don't have insurance, or you don't go to doctors, or you don't engage in good conversations with your doctors, you may not be screened. And so you may get detected later in your prostate cancer, which is usually without symptoms when most men get detected. And by the time it develops symptoms, it's oftentimes at advanced stages that require the medications that Dr. Dickey was talking about, where you really can't cure them anymore. You can only control it with taking away the testosterone, increasing hot flashes and breast tissue development, and really just kind of controlling the cancer at that point. Genetics is supposedly responsible for about 40% of this risk. And BRCA is one of the genes that was mentioned earlier that does really increase the risk of prostate cancer, and it's more common in African Americans. Most people think of it for breast cancer, which is why it's named BRCA. And it got famous when Angelina Jolie did a double mastectomy, removed both of her breasts to lower her risk of cancer, breast cancer. But it's actually a big in prostate cancer as well. And so I was said to believe that prostate cancer was going to be mostly about genetics. I recently did a study where we went to Nigeria, the birthplace of most African Americans, West African ancestry, and we looked on autopsy. And we found that the rates of prostate cancer in Nigeria at similar ages is lower than American Blacks and is lower than American whites. So it probably isn't just genetics. That was really surprising because I expected, because Blacks have this high risk and Afro-Caribbeans have this high risk, that the motherland would also see a similar problem. And while prostate cancer is the most common cancer there, it's much less common than it is in the US. So my bet now is that it's a gene environment interaction, meaning that environment impacts on the genes of people with African ancestry to increase the risk beyond that of American whites. And that can include diet, smoking, alcohol, stress, poor access to healthcare, medical mistrust, vitamin D deficiency, the ones that I study. And why I put this up here, this is another snippet from my own study where we looked at, after men had a biopsy, prostate biopsy, we drew their blood for vitamin D levels. And then they went on and had not only a prostate biopsy, but they had their prostates removed by radical prostatectomy. And we were trying to determine if vitamin D levels were predictive of what would happen at surgery. And it turned out that, in fact, people who had low vitamin D levels, which was defined as less than 30 nanograms per milliliter in their blood, had more than 2.5 times the risk of bad pathologic findings when you took out their tumors from the whole prostate. So those tumors were more often to be outside the prostate or be higher grade, for example. So that was statistically significant, and it really was in these people that we now sometimes watch with active surveillance, that it really increases this risk. So I've been a big advocate or proponent of vitamin D supplementation through multivitamins for African Americans for several years. I think Dr. Desai touched on another important part, which is about the downside of screening. People really don't want to go through the prostate biopsy. And while it's done under local anesthesia and it's pretty well tolerated, it still involves sticking a rectal ultrasound in the rectum of a man and then doing needles through the prostate, through the rectum into the prostate. And so people don't like it for those reasons. There are some tests that have been validated in African Americans and in other racial groups that includes free PSA, PSA density that Dr. Desai mentioned, and prostate health index. Some of the others that were mentioned, like 4K score, select MDX, have not been properly tested in Blacks or other ethnic minorities. And so we don't know what cut point should be used to define a positive and a negative test. But prostate MRI and prostate health index are the ones that I am kind of a proponent of. And I'm actually doing a research study funded by the National Cancer Institute of the NIH to figure out how to best use these tests in Black men and in Hispanic men. It's been determined how it should be used in whites already, and it's already a part of our national guidelines. And then I guess because we're getting kind of close to the end of my time, I wanted to just mention that there is a lot of hope, though, even though the mortality rates are higher in African American men, and we found out recently in certain groups of Hispanic men, mostly that have higher West African ancestry, but also Mexicans, that there is this higher risk of mortality or death from prostate cancer. But it turns out that Blacks actually, if they're on clinical trials, meaning they're getting good care at a good hospital, they do better than whites actually on androgen deprivation therapy, the medication that Dr. Dickey was talking about, like Lupron, Eligard, Zoladex, those medications. And they do better with therapies like a tumor vaccine, which targets the immune system. So they actually, if you are Black and you have bad prostate cancer, the treatments that are for that group of cancers can actually be better for you and may help you live a longer life. So I just think that it's a lot of room for hope. So my general prevention strategies, although Dr. Desai is right, the only thing is really early detection. There's stuff with good data that says you should really stop smoking if you're a smoker, reduce your alcohol intake to no more than 1 or 2 drinks per day. Beer, red wine, and other alcohols are included in that. Reducing red meat intake and processed meat like deli meats and bacon to no more than 2 times a week. Increasing your vitamin D intake to 2,000 a day or more is a safe bet, but it's better to get it checked by your primary care doctor. And while there isn't strong data in lots of the other prevention strategies, turns out that the VITAL study was done and finished up last year. It was published in the New England Journal of Medicine, a big popular cancer, a really popular medical journal, showed that there was a 12% reduction in prostate cancer. While the study was powered with looking at overall reduction of all cancers with vitamin D supplementation, they found a 12% reduction specifically in prostate cancer. And it was borderline statistically significant, meaning that the likelihood that it happened by chance was 6%. So that's pretty easy to recommend vitamin D for patients. And amongst the African Americans, it reduced overall prostate cancer mortality by 23%. And vitamin D deficiency is really common in dark-skinned people because of melanin blocking the sun's rays and our ability to make vitamin D naturally in the sunlight. So at the end of this, I just provided my email, which is dradamurphy@gmail.com, if people have general questions or want to be pointed in their direction of other general information about prostate cancer.
Thank you so much, Dr. Murphy. And I'll be sure to share, that's hard to say, your email in the chat box for everybody too. That's so generous of you to share your time in that way. And thank you so much for sharing this really critical information. We are going to invite our final speaker up to our metaphorical stage here. Maybe just one moment to introduce him. Kevin Jamal Salter. Kevin Jamal Salter is currently Vice President in the Commercial Bank Division at JP Morgan Chase. He lives in Chicago with his wife and 2 daughters. Kevin is a proud graduate of Morehouse College in Atlanta, Georgia, with a degree in business management, and is a member of Alpha Phi Alpha Fraternity Incorporated. Thank you so much for being here with us tonight and willing to share your story. I'm going to go ahead and spotlight your video, and thank you, Kevin.
Thank you. Thank you to the Cancer Support Center for just inviting me to share my journey. Listen to the doctors just, made me realize how much information is out there that people need to be aware of as you go through this process. And as we said earlier, I consider myself, I'm a survivor. About a year ago, this month, I was diagnosed with prostate cancer. And I want to say that is because of, the great benefits at JP Morgan. Every year we are given incentive to get physicals, annual physicals, to get medical reimbursement dollars, keep our insurance costs low, because I'll admit up front that if I didn't have that incentive, I don't know when I would go to the doctor, because I think, as Dr. Desai said at the onset of his presentation, there's not this cancer doesn't show a lot of symptoms. And I'm one of those guys, so as I tell the story to my peers and anyone who would listen, is that, I didn't think anything was wrong, and if I tell my story, because I want to be cognizant of time, just going through an annual physical, my doctor did the digital rectal exam, or as I call it, they did all the check engine light tests. When you reach a certain age, over 45, over 50, they are checking everything. And, it is humbling, but it is also necessary. And so through the digital rectal exam, or DRE, there was, I guess, something didn't seem right. And as the doctor said, they wanted to run some additional tests. They took a PSA test, or blood sample for me. And at that time, I was thinking anything about it. I had no symptoms. I didn't feel anything was wrong. So when they did the blood test, they were like, your PSA has jumped up from 2 years previous to where it wasn't a concern, to over 4. At that same time, I was still in denial. I didn't think anything was wrong. I'm going to the gym. I'm having a good time. I'm in good shape. But then going through that, they decided, well, let's do an MRI, which led to a biopsy. And as Dr. Murphy said, the biopsy, is something that you don't enjoy or look forward to, but it's necessary. And through the biopsy, they took the samples, and even after the biopsy, I had no concerns. I just thought maybe something was wrong, but I got a call, I think the weekend before Thanksgiving last year, telling me that 10 of the 12 samples came back positive, that you had, and told me I had cancer. And during that call, I know they probably talked to me 5 more minutes after that, the statement that I had cancer, but I didn't hear any words. It became more of a mental concern for me. So after I hung up the phone, I probably waited half an hour, called them back, and I said, I'm sorry. I know you were telling me something about my health, but I could not process what you were saying. So they talked me through it again and told me, you have prostate cancer. You should probably come in and probably do something soon. Because based on, I think, I don't know if anyone had mentioned before, also my Gleason score initially was a 7. The Gleason score is one of the other measures of the potential for prostate cancer. So through that, I think the biggest challenge for me was just the mental blow to say that, hey, something is wrong. And, automatically when you get those type of diagnoses, you automatically go to the worst case scenario. And I gave myself a few days to process. Didn't tell my wife, didn't tell my family, just wanted to figure that out. But, and finally telling my wife and family what was going on, the biggest thing for me was the support. And I have some good friends, another doctor, Dr. Courtney Hollowell from Strozier, is a personal friend of mine. He's also a urologist. And he just kind of talked me through the options. And I think one of the things that we as men, we've got to be able to listen to what the options are. He didn't guide me and tell me which way I should go. I talked through, do I need to get radiation? Do I want the radical prostatectomy? Do I qualify for active surveillance where they're kind of watching? And that was not an option. But through having those discussions and talking to other doctors, talking to a radiation oncologist, talking to another urologist, came up with the ultimate decision to have the prostatectomy, and which was done in January of this year. The surgery went well. My doctor, Dr. Edward Schaefer from Northwestern, said it went very well. They think that the cancer did not spread, which was one of the concerns. When you do that, you don't want the cancer to leave the capsule and spread to other parts of your body. So then very positive result. But then there's also the recovery, physical and mental, once again, because you are now questioning, did they get everything? Even though they told you they got everything, you still have doubts in your head. You still are now coming out of the hospital, recovering. Your body needs to learn new controls, because the prostate, once it's removed from your body, which is kind of the piece that helps produce a sperm, and also kind of helps you with bladder control, is no longer there. And those are things that physically and, like I said, mentally, ego-wise, that you struggle with, but it's necessary. I've been fortunate to think that when you get diagnosed, I think Dr. Desai said this, over 240,000 have it each year, but you feel like you're going through it by yourself. But the key thing is you realize you're not. There are great support groups out there. I was fortunate to reach out to, I think, a Facebook support group. The hospital had one, had some great people just kind of talk me through, my concerns, kind of lead me down the path, let me know what's normal, what's not normal, and which I've done now for others who are going through this as well, because, I've had my first PSA after the surgery, which showed less than 1, which means that it's not detectable at this point. But I'm still, I think they say another 4.5 years of testing twice a year before they clearly say that you don't have it or it's in remission. But I'm claiming that I'm a survivor now. But the key thing is making sure that, for anyone who has any concerns, that, you talk to your family, because I think, as Dr. Murphy mentioned, that there are some genetic markers in here. I mean, after I found out, then I talked to my family and found out, my father had it. He didn't mention it, went through it, with us around him, went through radiation. I find myself now talking to my peers that are in their 40s and 50s, saying you must get tested. If you must go get a physical. It may not be the most comfortable thing, but it's better to have that peace of mind to know either that you don't have it or that if you do, there are great treatments out there. The sooner you find out, the better the results are. These are all things that we need to continue to get the word out, especially for African-American men, because, I see that, even my peers who are not anxious to go to the doctor for whatever reasons, whether it's distrust, as it was mentioned earlier, or access, and maybe you don't have, you can't afford to go because you're worried about the cost. These are all things that we've got to get past, because the most important thing is, being here for your family and friends, as opposed to letting your ego stop you from going to the doctor. I will tell you that this is still a journey, letting your body relearn how to do things, from just bladder control to sexual function. All these things are part of it. But ultimately, the goal is to be healthy, to be recovering, and also to be someone who can reach out to someone who also is being diagnosed or going through the same process. So, I leave this to say that, we must continue to push our loved ones to go to the doctor, not to have excuses to avoid it, especially find out your family's history, talk about that so you can find out if you need to be getting checked earlier. Dr. Desai mentioned starting at 40. I mean, if you already know it's in your family, maybe even earlier than that. But this is an opportunity here for us to continue to spread the word, make people aware, because I think awareness is probably going to be the biggest thing. And I would tell you to use all these resources, find the support groups, because you are not alone in this process. So that's all I have. That's in my journey. I'm continuing on it. And I hope if anyone has any questions or is going through it, I'm also here, to be a voice, to share my experience.
Thank you so much, Kevin. And just thank you again to all of our presenters. You really, did quite a thorough job of answering most of the questions that we had come in. There were a couple that came up that we didn't touch on yet, a few actually regarding the prostate. So one of the questions was, is there any way to shrink an enlarged prostate, like any natural herbs or vitamins? And does an enlarged prostate make you more likely to develop prostate cancer?
I can start off with this, and then if any of the other panelists have something to add. I guess in terms of herbs and supplements to shrink a prostate, really nothing that I'm aware of that can actually shrink a prostate. There is a medication. I did briefly mention it. There's been many studies about finasteride or dutasteride, which are all 5-alpha reductase inhibitors. They actually shrink a prostate. They help with men with urinary symptoms. In terms of prostate cancer, there's some studies that came out saying that, people think that it increases your risk of prostate cancer. And when you actually look into the content of the studies, you come to learn that it basically lowers your PSA, which is basically the mechanism how the drug's acting, right? So it lowers the PSA, but that doesn't necessarily increase your risk of prostate cancer. Now, what they extrapolated or kind of implied was, oh, your PSA is lower, and all these men were getting prostate cancer at a higher Gleason score, right? I know Dr. Murphy mentioned Gleason score briefly, and for the the limitations on time, we won't spend too much time, but the theory is this, is that if your PSA, let's say, was 3 before you took any of this medication, now it's down to maybe just 2.5, didn't really change much. Then that true PSA would be doubled. And so if you've been on finasteride or dutasteride or these 5-alpha reductase inhibitors, you have to double that PSA if you've been on those drugs for 6 months. And so the idea is that it's increasing your risk for prostate cancer. I don't think that's really true if you understand the mechanism of and how the drug is working. And so again, this is something your physician would work with you. And so the final piece, I think that the participant was maybe trying to get at was in terms of a medication, or basically more so enlarged prostate and prostate cancer. There's really no increased risk of having prostate cancer if you have an enlarged prostate. And to be honest, one of the things Dr. Murphy mentioned, and we didn't talk much about it, something called PSA density. And so if you have a large prostate and your PSA is, let's say, 4, and your prostate's, let's say, 100 grams, versus a gentleman whose PSA is 4 and is technically 20 grams, that person with a 20-gram prostate might more likely have prostate cancer than someone with a large prostate. But there's a lot of data on there that goes kind of back and forth. And so I'm not going to say one or the other, but more times than not, a larger prostate and with a PSA usually does not necessarily mean the same thing as a smaller prostate. So I don't know, I'll leave it with Dr. Murphy had anything to add on that or anyone else.
Briefly, yeah, I agree with what you just said. You know, people who have big prostates tend to have low PSA densities because it's PSA divided by prostate volume, and just like you mentioned earlier, it's a protective factor from you actually having real prostate cancer. The finasteride dutasteride thing is interesting because it's been studied twice. And it reduces the overall risk of prostate cancer by 25%, but it didn't get approved because it increased the diagnosis of aggressive cancer 1.5%, and with 2 different studies, actually 3 different studies, and because of that, it didn't get FDA approval to prevent it, but we use it in people with prostate cancer and benign prostate growth as a treatment. And we have this 25-year data now on finasteride that shows that it doesn't increase prostate cancer mortality. So it's interesting. I think it actually probably does work, but it's a controversial solution, right? Do you agree?
Yeah, no, I think I would agree with you on that point. I mean, I think it's on the surface, you have to understand some of the numbers behind it. And I think that's the thing where the studies argued where you have to truly understand what the PSA is doing and have to understand that, I think, so.
Thank you both. Another question that came in was whether or not an active sex life helps prevent prostate cancer or makes you more susceptible. Anyone up for that question?
So this is a theory question. Dr. Desai, you have a different answer. I'm curious. What I tell people is that the studies on sexual activity show that people who have sex more often, like 2 to 3 times a week or more, actually live 2 to 8 years longer than people who don't. So now you could make the argument that people who are having sex more often have more quality relationships with their partners, and they're also healthier because they can take the exercise of, the calorie burning of sexual activity. And so maybe that's why they live longer. I use it as an excuse with my wife all the time to say she's killing me. If she does, no, I'm joking. That's a joke. There is another alternative thing though, which is the idea that you should have sex in a protected manner, because if you have prostate inflammation, that's one of the other pathways to prostate cancer, it seems to be. And that's probably why it may be that the immunotherapies work so well for African Americans. So having STDs increases your risk of inflammation, which may increase your risk.
Thank you. I actually had a non-prostate cancer come in through the chat box, just wondering how colon cancer is detected, if anybody felt like they could answer that quickly, because I do know we're, right at like 7:03. So I'm gonna give us a few minutes.
Obviously don't know too much about it, but I know there's obviously newer data that talks about a screening colonoscopy a lot earlier. I know conventionally used to be the age of 50, it's down to 45. I think there's been some, can't think of the celebrities off the top of my head right now, but I know there's definitely some names that will probably come to me after this talk who had colon cancer.
Chadwick Boseman.
But yeah, that's what I was just going to think of.
Right.
Yeah, Chadwick Boseman, right? And so I think that's the biggest thing. And I think one thing I will point out with colon cancer and screening colonoscopies, a lot of organizations, and you could probably maybe know about this with your organization, they actually have it where you don't actually even have to see your primary to get to the colonoscopy, right? Hospitals have it set up where you can get directly in to the gastroenterologist, which is a specialist for the colonoscopy. So you can skip that step, skip the office visits. And that's the important push, right? Because I think the thing I think to take away from this whole talk, I think today for prostate cancer, even with, it's about preventative medicine and early detection, right? I think Kevin mentioned it, right? Most men are not going to have symptoms with prostate cancer. You're not going to have symptoms for a lot of things. And it's about preventative medicine, right? Prostate cancer, you can do a lot of active surveillance. We didn't talk about that, but and the same thing with colon cancer. It's a little different. It's definitely a more aggressive cancer for many men, or many women in general, but it's about the early screening. So you have much more at your disposal as opposed to coming in late in the game and behind the 8 ball, where you just have one treatment option or 2 treatment options, or maybe none. And that's the biggest thing.
Our final question, and I'm so glad you asked this, thank you, Fred Arnold, is how to direct someone without insurance to free screening areas or sites.
In the COVID times, it's becoming kind of weird now because it used to be pretty easy to do that. The Cook County system still does, obviously, charity care, and if you have make less than a certain threshold, you can get free care through or an Affordable Care Act program and get screened that way. But normally in the summertime, there are health fairs. I lead several from Northwestern. There, UIC has several. I'm sure that Dr. Desai is probably aware of some as well, where we would go out into the community and do them at churches or at community centers and at fraternities. So for right now in the COVID era, the county hospitals still allow for free care. You come in and get a primary care physician first, and you have to ask because not all primary care providers will do it without a request.
That's good to know. And I will definitely follow up this presentation later this week with some other resources too that we've been able to put together. And part of our Kick It Cancer initiative is to get some screenings going, hopefully in the spring as soon as we're able, so that we can get these screenings available in our communities to the individuals who need it and might be dealing with lack of insurance for sure. So I want to thank all of our presenters. This information was so critical, and just thank you for your time, your expertise. It was phenomenal. I want to give a quick shout out to Hubert Stalling and Fred Arnold, who are members of our Kick It Cancer committee. And then just huge thank you to the men of Omega Psi Phi Fraternity Chi Lambda Lambda chapter, who just helped make this event so successful. And I think are really living the message that Kevin gave to us all of we need to talk about this with each other, with our families, with our loved ones, and just bring it to the forefront and make sure that everybody is able to get the screenings, get the early detection that they need to really reduce these cancer mortality rates. So just thank you all again. Please don't hesitate to reach out to any of us if you need anything at all. And with that, I hope everybody has a wonderful evening.
Thank you.
Thank you.
Thank you.
Thank you. Take care, everybody.
All right.
Bye.
Night, everyone.